right. Hello, everyone, and welcome to our webinar. Today, we're discussing a topic that's becoming increasingly important for oculoplastic surgeons, and that is modern approaches to ptosis evaluation and documentation, with insurance reimbursement requirements becoming more specific, especially around visual field testing. Our goal today is to give you practical, clinic-ready insights that make compliance easier and support consistent, high-quality patient care. Quick introduction, I am Jessica Marabella, our Content Marketing Manager for Virtual Field, and I will be your moderator today. If you are unfamiliar with us, Virtual Field is a next-generation eye care diagnostics and workflow platform that replaces outdated, bulky, and restrictive equipment with a portable, automated, and patient-friendly solution delivered via a lightweight headset. Next, a few logistical notes. Everyone who registered for today's presentation will receive a copy of today's slides and the recorded presentation within 48 hours. If you have questions at any point throughout the presentation, please submit them via the Q&A panel. Your questions will come to me and I will ask them live to our presenters. Any questions that we don't have time to answer, we'll provide responses to as a follow-up via email. And now let me introduce our expert guests. Dr. Dimitrios Sismanis is an oculofacial plastic and reconstructive surgeon based in Richmond, Virginia. Board certified in ophthalmology and a fellow of the prestigious American Society of Ophthalmic Plastic and Reconstructive Surgery, Dr. Sismanis leverages his extensive expertise in periocular and facial surgery, along with his background as an ophthalmologist, to deliver optimal aesthetic results while preserving the function and health of the eyelids and eyes. Dr. Sismanis treats and specializes in such conditions as heavy or droopy upper eyelids, loose lower eyelids, heavy brows, benign and cancerous eyelid and facial lesions, tearing problems, thyroid-related eye problems, facial and orbital trauma, tumors of the eye socket, and facial paralysis. Now, in addition to a busy functional practice, Dr. Sismanis also has extensive training in aesthetic surgery, offering a variety of surgical procedures, including upper and lower blepharoplasty for hooded, puffy, or wrinkled upper and lower eyelids, forehead lifts, and mid-face lifts. Thank you so much for being here today, Dr. Sismanis. I
Thanks
am
for having me.
also I am also pleased to be joined by Johnny Davis, our sales director here at Virtual Field. After Dr. Sismanis' presentation, Johnny will provide a quick demonstration of our Superior 36 exam. We'll, of course, provide information on how to book a one-on-one demonstration of Virtual Field as a follow-up to this presentation for anyone looking to level up their testing capabilities. Here is today's agenda. Dr. Sismanis will start with a brief overview of ptosis, what it is, why it matters clinically, and how it's traditionally been evaluated. From there, he'll discuss current challenges practices face with visual field testing, everything from workflow inefficiencies to meeting insurance reimbursement requirements. Next, we'll shift into clinical application. You'll hear how ptosis testing appears in real-world patient scenarios and how surgeons like Dr. Sismanis are currently navigating documentation and compliance. After that, we'll introduce our virtual field solution and explain how the Superior 36 ptosis exam can modernize this part of your workflow. Johnny will then provide his live demonstration so you can see the test in action. And finally, we will wrap up with a live Q&A. Now that is enough for me. Let's get started. Dr. Sismanis, the virtual floor is yours.
Excellent. Thank you. Okay, I think just to start off, for those unfamiliar, I suspect most people who are listening know what ptosis is, but ptosis is true drooping of the upper eyelids. There's a variety of causes, but often it is a just kind of a wear and tear phenomenon where the tendon of the lifting muscle slips. And I think as from the patient perspective, the biggest manifestation is the loss of the superior visual field. They're often complaining of missing things in the top of their vision, bumping into things, and actually their peripheral vision as well. Things like checking their blind spots when they drive. And with that, you can have some postural changes that lead to neck strain and other issues. Aesthetically, when it's unilateral, you can see asymmetry. Patients often complain of looking tired. And so these host of issues often bring patients in, and then it becomes our responsibility to determine not only what the problem is, but if this is of visual significance, if this qualifies for insurable surgery. So I think we can go to the next slide. And so I like to think of it actually from the right side of the screen to the left. First, the patient has to come in with visual complaints and kind of some description of how their activities of daily living are affected. I think in my experience, it's often they complain actually a ptotic lid when you try to read. It will drop further. So difficulty reading, difficulty checking their blind spots, bumping into things. Often they'll report elevation of the eyelid helps their field of vision. They report subjective things like things looking brighter and it's easier to see. Certainly, it's not going to improve how they read on the chart, and I think that's important to be clear with patients about that. But these subjective parts are very important. From there, we need the more objective evidence, and there's two things we need to document. And the first is photography, documenting a marginal reflex distance. Honestly, I think the CMS criteria say 2.5 millimeters, but I don't like dealing in half millimeters. So I say an MRD1, meaning the distance between the light reflex and the edge of the upper eyelid, of 2 millimeters. The upper lid has to sit basically within 2 millimeters of the center of vision. We document that with flash photography, the patient looking straight ahead, and we need to get oblique views, 45 degrees on either side to document this. And so from there, really, I think the most important thing that the insurers are looking at these days is the visual field testing. And so that's the third part of this criteria. The second objective measure that we have to document the patient's not only visual field impairment, but also this documents their potential for visual field improvement. And that's very important. We're not going to do a surgery for insurance purposes if they have no potential to see better after this, meaning see better peripherally. And so whether it's automated perimetry or other field forms of visual field testing, this is a requirement for every insurer that I'm aware of at this point. We need to document 12 degrees or 30% visual field improvement. And so we get their fields initially untaped. You should usually see quite a visual field defect. Then we tape it, and that's where you see the improvement. So I think we can move on. So traditionally, I think, particularly a lot of my colleagues, I think they like the Goldmann. Some of them may do it themselves, or they have a trusted tech who does it. It is an older machine. I don't know if you can still buy Goldmans, to be honest. It is a little bit more time consuming. I mean, again, some of my colleagues feel like they can whip through them pretty fast. But I think at this point, a lot of insurance carriers are not accepting perimetry that is not automated. So that brings us to the Humphrey visual field. That's historically what's been used. Used it for glaucoma screening and for tracking the function of the optic nerve. And I think a lot of folks are still using these. They are very costly and they're very large. And I think you have to dedicate a room to these. You have to bring the patient to it. And I mean, I don't know about my colleagues, but many of my patients are elderly. They don't ambulate well. So that not only just getting to the room is challenging for them, but also sitting in the machine can be challenging. So I think, that's kind of where the virtual field shines, and we will talk about that more. But I think basically we're looking at automated perimetry versus not automated manual perimetry. And that's kind of the dichotomy that we see right now. And obviously, virtual field is a form of automated perimetry. So, next. So the virtual field does have a kind of Ptosis fields or superior 36. And it's a pretty fast test, I'll tell you. I think the benefit not only is the algorithm pretty fast, uh, it is not intensive for the technician, It is done through an HTML based application. You can have it up on an iPad or a laptop. So my techs get the field going, and then they go out to kind of the nursing station, and they're doing something else, putting in meds or something for a patient, and just kind of watching. The machine itself gives feedback to the patient. So if they're misbehaving, if they're looking around, they will get feedback that previously with, like, for instance, the Humphrey, a technician would have to give that feedback, and they'd have to constantly be watching the patient. So it does, not only is the algorithm pretty fast, but just generally the process is streamlined. And I find that very beneficial for our workflow. Not to mention that it speaks multiple languages. So whether it's, Spanish or French or Mandarin, it does really help kind of walk the patient through it so your tech can do something else. So next. So I think we've covered some of this, but I think one, it does give you a pretty accurate test. It does do it pretty quickly. And it is the simplicity I can't stress enough. A lot of my techs are not certified ophthalmic techs or COAs. They have no background in ophthalmology, yet, even we have MA students come through. Even the MA students can run these tests with very little training. And technically, the app is very straightforward too. So it is it's a fast test, and it is not technician intense. And I think the most important is the patient comfort. Generally speaking, my patients do find this because, a lot of my patients have had Humphreys before, and I do tend to ask them, I'm like, how do you feel about the test? Was it comfortable for you? Did you have any challenges? And I think most of my patients, who again, they're often elderly, they seem to take the test well. It's pretty comfortable for them. Rarely we have the patient who doesn't want to mess up their hair. So there is a stand if they don't want to wear the headset. But generally speaking, it's something that it really is easy for the patient to do, whether they're in a wheelchair or they're kyphotic, meaning they're kind of hunched over. It is an easy test for them to do. So next. So yeah, I mean, I think I've summarized all this, but I do really appreciate the virtual field. One, for its simplicity, and two, for its portability. I think a lot of us have satellites. It comes with a little box, and we just take it everywhere we go. In addition to that, with the leasing model, which is what we do, not only does it pay for itself within like a few uses, like, I think I heard 4 uses. We probably quadrupled that volume in a day. So, I mean, not only does it pay for itself, but if something were to happen to it, I don't know about you guys, but my techs don't treat the devices like they're theirs, right? So sometimes they're probably not as gentle as I want them to be, or, patients, they may drop the remote, or they may take off the headset before you could get to them. And so if anything happens to the device, in my experience, I think we've maybe replace the headset once, if at all, and we've been using it from like the very like early on. I mean, at least 2020, I think. So we've been using it for a long time. Maybe replace the headset once. I can't even tell you definitively. And then the handpiece maybe 2 or 3 times, and they're always overnighted, and we're never left kind of struggling. I think it's reliable in that regard as well. And then, I mean, for us that own our own practices, I do, one of the biggest parts of my overhead is rent. And, we have not only our office, but our satellite office, so we rent that for the day. But, I can't take up space for a Humphrey. Not only aside from the cost of a Humphrey, the rent of that room, I can't give up a room just to run fields. So, I think these are the big benefits. And then clinical workflow, just, we can. either as the patient, when I'm done with the patient, we can run the field in the room, or if somehow we're short on rooms, we'll take them to we have like a little kind of waiting room where the patient waits to meet with my scheduler. We can run it there. We can run it in the scheduler's room. So the flexibility of that helps us get through the day a little bit faster. And then in terms of like the printouts, this is another form of efficiency for me because they are kind of dummy proof in ways that other printouts are not. Like sometimes, a lot of times, my referring docs will send taped and untaped fields, or at least untaped fields, and they're faxed, which is how we often submit our materials for authorization, right? And I can't read them. So immediately I know we're not going to get a good auth with that. So I will often run the field again. The software generates a PDF that can be dropped into the EMR, which is just like generally efficient on desk days. My staff just print out. I mean, unfortunately for me, while I'm in the OR, I'm getting like 20 or 30 fields dropped in my inbox to review. So my staff just do that on their off days and it doesn't take a lot of time. And the printouts are very clearly understood. You see the percentage missed both on taped and taped. So it's very clear that you're getting a 30% improvement and it's very legible where it sits in terms of degrees. I don't remember having to do a peer-to-peer for this, like either, yeah, and we say ptosis, but the same applies for blepharoplasty, for brow lifts, functional upper lid or brow surgery. It's all the same. The criteria, other than photography and clinical exam, the ptosis or the field requirements are the same. So I don't recall having to do a peer-to-peer for any of the stuff for quite a while. And we don't get paid much for this. It is time intensive, not only in like kind of the exam and talking to the patient, but the phone calls that lead up to surgery and after surgery. And then if you had to add managing the insurance companies even more past an authorization, really the potential to generate any revenue off of functional upper lid surgery suddenly starts dwindling. So it is, to me, it is a great convenience to have a nice, easy printout that usually, if if it meets the criteria, it meets the criteria, and there are no further questions from insurance companies. It's been a huge improvement for us.
Well, thank you. Thank you, Dr. Sismanis, for your insights and your feedback. We so appreciate it. I would now like to reintroduce our Director of Sales, Johnny Davis, to provide a demonstration of our Superior 36 exam. Welcome back, Johnny.
Yes, thank you so much, Jessica. I'll go ahead and go into a screen share for this exam. So as Dr. Sismanis was mentioning, everything is going to be web and cloud-based pertaining to virtual field. So there's no application needed to download. The headset is portable, so it does provide simplicity. As he was stating, you can take it from location to location. You just need a stable Wi-Fi connection. So this is the headset. Now, for accessibility and what your techs are going to do in their day-to-day, they would just go into our web domain, which is the virtualfield.io. And from that standpoint, in order to access their encrypted secure portal, they would just elect to sign in. Now, if you guys are operating and have multiple offices, you can have login credentials per provider, per location, per tech. This is all going to be discretionary. Once you elect to sign in, it's automatically going to reflect the headset that is connected to your account. You can log in from multiple desktops within your clinic, so you don't need a dedicated PC or tablet for this. So just when it comes to queuing up the exam, we provided these steps just to be very straightforward and seamless for your technicians. We want to enhance the overall efficiency when it comes to operating within your clinic. So I'll just do a quick click to add here. As far as for the queued exam portion, I'm going just to select the Ptosis Superior 36 exam for us to run and conduct today. But everything that you're reviewing over here is going to be customizable. So you can change stem size. You can slow down the exam speed for your elderly demographics just to maximize your efficiency a bit. You can select the order of eyes if you're going to do both eyes. If so, then it'll go right then left or left then right. And then the language preferences and settings. So for your multicultural patients, you can change the language setting. So this is going to be very key if you have a very diverse patient population. So I'll queue up this exam just for one eye for today, and we'll begin the exam. Now, as far as like speed accommodations for this, just for one eye, it's going to take between about 30 and 45 seconds to complete. I'm going to make a few mistakes so you all can hear some of the words of corrections because the headset will guide the patient throughout the entire exam. So headset is very light on the patient's head. If a patient is claustrophobic or whatever the scenario is, or let's say they got their hair done, they have a ton of makeup on, they don't want to place the unit on their head, we do send out a headset stand as well. So we found multiple avenues just to accommodate your entire patient population.
Welcome. Let's adjust the headset so it follow the blue circle with your eyes.
And the blue circle within the headset is actually moving, so it just calibrates to the patient's eye and it does handle those occlusions.
Great. In the upcoming exam, you will see small lights, like this one, flicker on the screen. Some lights will be bright and others will be very dim. Click with your finger whenever a light is shown. Now, do you see the orange circle in the center? Keep your eyes focused on that circle until the test is finished. You can blink normally, but always look at the circle. Please ask a staff member if you have any questions. When you're ready, click to start the exam.
And for us today, I'm going to make some mistakes. So if your patient happens to get trigger happy,
Only click when you see a light flicker on the screen.
if your patient gets tired, let's say it's an 8 o'clock exam slot, the headset will correct the patient. It does take about 3 to 5 seconds in general, but we're going to get through this today.
Only click when you see a light flicker on the screen. You're halfway through the exam. Excellent. I've moved the orange circle. Focus your eyes on it, then click to continue testing.
Perfect.
Only click when you see a light flicker on the screen. Test complete.
And your reporting and results will populate instantly, and then you have multiple ways to get it sent back over to your EMR system. So you can download these to a network folder and just send it back over to your EMR system, or you can do a print and scan option. But there is a box and field where you can take notes. And of course, this exam was an untaped. If you need to tape, then you can just place a note. That way it does appear within the report and it will showcase that that exam is taped. So it'll be right over here in your notes box. I'm going to pass it back over to Jessica.
Thank you so much, Johnny. I am going to launch a quick poll for everybody. If anyone here would like a one-on-one demonstration with Johnny, you can indicate that for us with the poll. I'll leave that up for just a few seconds. Now I'm going to go back to sharing my screen. We did have just a few questions come in. I want to make sure that if you have a question today, that we get that answered for you. First question, I think probably for Dr. Sismanis. Do you recommend, I think maybe you touched on this earlier, but do you recommend including photos alongside field tests when submitting for insurance approval?
It's part of the criteria. Yeah, you absolutely need photo documentation. You need taped and untaped visual fields, and you need a note documenting how this is impacting the patient's activities of daily living.
Thank you. And I think this was probably demonstrated a bit during your demonstration, Johnny, but there was a question, how does the headset handle patients with ptosis on only one side?
So handling patients with ptosis on one side, you just select the order of eye. So you can choose that, and then from that aspect, then you can still perform the exam. Just means the other eye won't be really being tested for the ptosis.
I think to clarify, the patients don't often get this, but the way the headset works, there's like one screen for each eye, right? So it's like, even if they're wearing it, it's only testing one eye at a time. There's no need to occlude an eye, which is another thing that we have to do with other forms of visual field testing, right? You don't have to occlude the eye with this. You just put the headset on, you can test, it only tests one eye at a time. It's not testing the field of vision for both eyes at the same time, but it will sequentially check the right eye and then the left eye, or vice versa, the left eye and the right eye. So no need to occlude.
Thank you. Thank you for that. Just one more question. What happens if a patient has difficulty maintaining fixation during the exam?
Yeah, so the headset will correct the patient. So if they're not focusing on the fixation target, the headset will notify the patient. That way they can continuously focus on a point. That way they can get through the exam as thorough as possible. But if they're not focusing, the headset will notify the patient.
I will say it's pretty rare that we can't get useful fields in patients that have decent vision, that is. Now sometimes patients have glaucomatous visual field defects or whatever, and they're just not going to qualify for surgery. But it's pretty rare that I see a patient has no other ocular conditions. I say, hey, from a physical exam standpoint, you qualify, and then we run the fields, and they don't. Now, rarely, patients are really used to cranking their forehead, pulling up their lids. We do counsel them to try to relax when they take the test, to give us an honest test. There is an occasional patient who just to save their life, they can't do it. There is a bit of a learning curve for the patient with visual field. So we do I'm out of the office a lot. I operate at least twice a week, sometimes more. So when I'm not in the office, for those patients who have challenges, we don't hesitate to bring them back and let them sit down and take the test a few times until we can get a reliable test. So, but it is, I will tell you again, I don't know. I mean, my staff made slots for lid evals now, so I see a ton of droopy lid consults in a day, and it is pretty rare that like numbers wise, I see maybe 50 patients in a day, 20 to 25 new patients, and of those, at least 12 to 14 of them, if not more, are lid consults. So it's pretty rare that we have to bring them back. It's a pretty easy test to take and a fast test. I think that's where when it gets long, that's when patients struggle.
Well, thank you. Those were all of our questions. So, before we wrap up today, I'm going to drop some links in the chat so that you all know how to get in touch with Johnny, as I said, in case you have additional questions about virtual field or would like to take a demonstration. Once again, thank you, Dr. Sismanis, and thank you, Johnny. And thank you to everyone who joined us today and to all the vision care heroes watching this recording who are helping provide exceptional eye exam experiences every single day. Thank you for what you do. Until next time, take care of yourselves. Goodbye, everyone.